just to have a background of the disease, we all know COVID-19 has been a very big disease burden all over worldwide, and in India, till date, we have about 4.4 crore cases which have confirmed, and it has been very difficult to differentiate during those times breathlessness between of acute onset of a COVID disease or a cardiac disease, and sometimes even after the disease has progressed, respiratory functions like after 7 days, 14 days, we think it to be as a COVID disease itself, but sometimes it is a cardiovascular lying underlying worsening. So, and it is also said that at least 20 to 25% severely ill COVID patient experience a cardiac injury as well. So echocardiography features has been a very limited data during those times in COVID-19 infection, and natural history was also very unclear, and we had very limited data of cardiovascular involvement that time. So now it is a bit more clear about the acute and the long-term effects of the COVID-19. And due to high risk of infection, this data was limited as it was not recommended in appropriately unless it was not appropriately indicated. So we did a retrospective comparative echocardiac study to compare the echocardiographic features in Indian patient cohort during COVID-19 infection between wave 1 and wave 2. This was a retrospective comparative analysis which included moderate to severe COVID disease patient inpatient between the first wave, which was March to June, and the second pandemic wave, in which we could do transthoracic echocardiography. We did the comparative analysis and chi-square testing. So the mean age was relatively, we had younger patients in the second wave, and males were more predominantly affected in both the waves. Coming directly to the LV functions, so about 25% patients were having some LV dysfunction in wave 1 and 18% in wave 2, out of which severe LV dysfunction was found in about 5.9% patients in wave 1 and 5% in wave 2. So compared to the age groups, we found that although severe LV dysfunction was prevalent in age more than 65, but also what we found was that even mild to moderate LV dysfunction in younger patients, which was less than 45 or even 45 to 65, we comparing to in wave 2, when compared to wave 1. LV dysfunction had a regional wall motion abnormality in about 10.3% cases in wave 1 and 8.6 in 2, and a global hypokinesia in 13.5 and wave 1 and 10 in wave 2. Diastolic dysfunction was much more common rather than systolic dysfunction in about 28% cases in wave 1 and 28% in wave 1 and 29% in wave 2. RV function, although was a very common interest of topic during among echocardiographers, but however in our study we did not found that much of RV dyskinesia and moderate, we found only moderate PEH, mild to moderate PEH in wave 1 and wave 2. This was also non-significant. We compared clinical severity with the dimensions. So what we found was that RA and LV dimensions were a bit more higher in clinically severe patients in both the waves. Pericardial effusion was mild to moderate, very less percent were in having a large pericardial effusion. So coming to the outcomes in which whom we did an echocardiography in which whom these echocardiography was indicated, they had a longer hospital stay, which was about 2 weeks, and the final outcome of mortality was 43% in wave 2, wave 1 and 38% in wave 2. Obviously, the LV dysfunction when severe had a higher mortality in both the waves. So, so males were most commonly affected, and what we saw that when transthoracic echocardiography we had a higher number, which was 590 patients, because we first of all had appropriately indicated transthoracic, like we did it only in those patients who had a longer hospital stay, hemodynamic assessments of unexpected shock and high oxygen requirements, lack of clinical improvement, sudden worsening of any pre-existing cardiovascular abnormalities, and if we had a concern for major cardiovascular events. We had strict protocols, we had a shorter duration of exposure, change of duties, then we only did minimum and selective acquisition of images and clips. We also had a clinical profile of patients in our center, which was very high voluminous. We had about 3,000 patients of moderate to severe disease, out of which we were able to do 590 echocardiographies, in which we found that LV systolic dysfunction was found in 25%. And then what we want to give a message is that mortality rates were higher in patients requiring echocardiography in first and second wave when compared to the general COVID-19 patients in whom this echocardiography was not indicated. So a targeted echocardiographic surveillance is a very good tool for guiding us to what it is the cardiovascular involvement. And LV diastolic dysfunction is more common. Transthoracic echocardiography should be considered in a hospital who require a longer hospital stay for hemodynamic assessment sometimes, and any concern for major cardiovascular events. The middle age was more commonly affected, had a higher prevalence of mild to moderate LV dysfunction, and severe LV dysfunction had a higher mortality in both the waves.